Just to let everyone know, we're still waiting for Pam Smith to log on, and that should be very soon. Apparently someone has seen her today on a Zoom call.
We did. We just saw her.
Okay.
Oh. Pam says she's trying to get in right now.
Okay, great.
She should be logging in.
You can talk right now, but I cannot do the video. I don't know why. Oh, here.
Yeah, she wants the microphone on.
It looks like Miss Stewart just joined us. Christian Stewart, I believe that was. Here comes Pam. She's coming in now.
There, I see Pam.
She just joined.
Hi, Pam.
Hello, sorry, it was, didn't want to let me in, so.
Okay. I'm glad it did. Do we not have a quorum, do you know?
I only saw you and Miss Stewart log in. If I missed someone, please let me know.
Okay,
Let's
so
scroll through.
okay, so we'll call the meeting to order. We will dispense with the approval of the minutes. Pam, did you have some numbers to share with us?
I do, so, and Aaron, do I have, can I share, will you, give me permission to share?
Yes, ma'am. Let me.
So the 30-day discontinue notices, that is a very manual process, so I asked them to go back and refresh those numbers, so, I'm waiting on that, and then, I can give you what we know about how long they've continued to receive services. What I'm finding is I don't know if it's going to be how much value it's going to be, because a lot of it just looks incomplete. Like the data that we have doesn't show, you know, what they've been doing. So I've asked them to add that, but then I want to show you the claims data.
Yeah.
Figure out where I have it. Figure out what screen I have it on. Okay. So, and then I will send you all this as soon as I can. Let me bring it up here. It's taking it just a second. But we looked at it's not bringing it up. Okay, hold on, let me try this again. So I have 18, 19, 20, and 21. And then what our data person did is she actually did a graph. So let me bring up the graphs first. My computer is not cooperating for anything today, unfortunately. Okay, so let me know if that comes up and you can see it.
Haven't seen it yet.
Okay, let me. Aaron, it says, okay, so I'm having, can you stop my share, Aaron, and then let me try again? It says that Zoom is not responding, so.
Yes, ma'am. Okay, try it now, Pam. Pam, if you can't get it to work and want to email it to me, I can try to share it on my end. I think we lost her.
Lost Pam?
I think so. I don't see her.
Oh, no.
It may have kicked her out. She said she's trying to log back in. Give her just a second.
Okay.
Here she comes.
All right. I want to add too, we have Erin Bickers with us. She's taking over. She'll be our TAC liaison from now on, correct, Erin?
Yes. Hi, guys. And I will drop my email in the chat for anybody that needs to get a hold of
Okay.
me.
Okay, thanks.
You're welcome.
Aaron, I think you need to give me permission to share again. And
Oh,
I said, if this is any indication of how the rest of the day is going to go,
Let's
I'm
go home.
gonna
Yeah.
go home now. Yeah, I'm gonna just stop
Are
now.
you guys back in the office?
We are some, like today I'm at home, but I go in usually a couple days a week. You know, the commissioner and the deputy commissioner and deputy commissioner Cecil, I think we're in the office today. So we alternate so that there's somebody in the office pretty much
Okay.
every day.
All right.
Okay, so let's try this one more time. And so my charts tab closed, so I'm going to show you the detail tab, which is this is what you all are going to get. And I think it's going to work this time, it looks like. Okay. Well, let me know if you're seeing something that says SCL July 2018 data at the top.
Ah, yes.
Okay, So this is the summary that our data person did. And so what you all are going to see, the revenue codes, you're going to see these number signs in, and that's just specifically because SCL does not use any revenue codes. We use all procedure codes. But what she has done is, so she's given you, so it tells you how many, this is for 2018. This is going to tell you how many unique individuals were billed. This is the total number of the units, and this is the total amount billed versus the total amount paid. It gives you how many unique providers billed, how many unique provider member combinations there were. So again, I said this, it tells you who the top provider by the paid amount is, the top procedure code by individual provider. Of course, revenue code, there's going to be nothing to report. Again, you're going to see this, the top procedure code is residential, which I don't think will surprise anybody. And then that's the total for July of 2018. And then this is the top diagnosis code and the total amount that was paid. Then it goes down, it breaks down into, so the top 3 procedure codes. So again, residential has several codes. We didn't add the modifier on there, so we can go back and look about doing that. But the amount paid in July of 2018 for that code. So then looking at paid across providers, so you see the average, the minimum amount, and then the maximum amount that was paid. And then across members, so you see the average that was paid for a member. You know, we did had some members that didn't bill any services in July of 18, and then the maximum per member. So then page 2, we actually get into the breakdown. So the unique number of members that were served, the ICN submitted, we left it on here, but it really doesn't. You know, an ICN is going to be, so that's your claim. So it depends on how the provider decides to bill. You know, you may bill one day at a time, and so that would be one ICN. Or they may decide to bill at the end of the week. Excuse me. So that would have 7 days on it. So that number really doesn't tell you a whole lot. This is the units billed versus the units allowed. And then this is the amount billed versus the amount paid. We went ahead and threw the difference on here, but a lot of times so this just means we paid the maximum allowed by Medicaid. So that, of course, is quite lengthy because it gives you several, all of the providers. Then the one piece I think that is not done yet that I need to have her go back and do is to break out what these units are. So what, how many units of each code?
Yeah, I think that's kind of what we were looking for is the type of service comparison, you know, to see, particularly to see maybe how, for example, how COVID affected the amount, you know, the units of service.
Right, like
for
day
IDD.
training or so we will, I'll have her go back and add that on. And then I will send these out to you, Rick, and then you can you can distribute them. And
but that would include the comparison by year for the types of service.
Yes, so she did. There's also a, so we will add to the chart she's already created, but we did look at, you know, the number of members, and, you know, the number of members actually went up each July. And this is specifically only for the month of July.
Right.
So that is, you know, there was a lot of information that we sifted through. So I'll have Miss D, my data analyst, to go back and add that additional information about the specific procedure code so that you can see how the units changed over the years between 18 and 21.
Yeah, would it be just as easy to use January as July? I think at the time.
You tell me. I actually have state fiscal years. I have this full state fiscal years from I have 17, 18, 19, 20, and 21. So I have the last 5 full fiscal years worth of claims data. So I mean, we can give it to you in a different month. We can give it to you in
Sure,
the full year.
It doesn't matter. Well, I would say if we use January, that's more current information, right?
Well, you have to be careful because there's a delay in billing. So providers have
Oh.
up to 365 days to bill. So we typically don't use current year until, we're at least, well, I guess we're 3 months in, but it usually is not as accurate because you may have some claims that are not included yet. We can add, and I don't have that. I can certainly get it pulled. And if you want me to add January of 22 so that you can compare
Yeah,
across, the previous years across through to January, looking at January of this year, we can do that.
well, I don't know. I would assume January is fairly complete, right? In most cases by now, here in March.
I mean, it should be.
Yeah.
We don't typically have providers that wait the 365 days to bill. We typically, when we're doing the
Yeah.
big data comparisons, we wait about 6 months. But I can get the data with the caveat that it may not be complete. So I can pull January just with the understanding that there may be some claims that are lagging.
What does anybody have an opinion on that? Is January adequate for our purposes? I think it is. So we'll use January.
Okay. All right. So I'll have her do, and we'll do kind of the same format. I'll have her go ahead and we'll remove some of the revenue code stuff and some of that detail that really isn't like that. It doesn't have, it's not relevant. So we'll have her do that, but I will do that. And then, so let me go back to, Erin, can you pop the agenda back up for me? We're looking at the claims data right now. I did talk to the behavioral health team and got a couple of specific codes that could be used for behavioral health. So we're going back and refining that because I think, Rick, as I told you, that I had hospitalizations, but it literally was for was ER visits. And it literally was for every code that we captured the diagnosis code, but we've refined it and are going back with some specific behavioral health codes. So she's working on that as of right now. So I will, today is Tuesday, right? So by the end of this week, I should have that to send out to you all. It'll probably be next week just because I have to get the 2022 data before I can send you the updated, this updated comparison code. And then incident reports. So we are looking at it because we did not require the use of MWMA for incident reports until late 2020. So we have to go back and look at the spreadsheet. So that one's a little complicated to get, but we're looking at overall, I'm going to give you information on just the trending of incident reports that we've seen across, at least for 2021 in SCL and Michelle P, the types of incident reports that we had by category. And then we're working on capturing the exceptional supports in the incident reports. It's a little complicated since we don't have really 2021 is the full year of data in the system so that we can capture it without having to, go through the spreadsheet. So, but we're still getting that for you. By Friday, I will be sending you at least the hospitalization data. Maybe I should have the critical incident report information by Friday too. And Rick, is it okay if I just send it to you?
That'd be great.
Distribute it? Okay.
Yeah, and that'll be helpful. Just as an anecdotal, I don't know how to maybe capture this, but I'm just seeing a lot more from case managers referrals for residential services. All of a sudden, there just seems to be a spike in that, and I don't know what's going on. Has anybody else noticed that? That people who apparently they're difficult to serve, or their providers are going out of business, but it seems like there's just a lot of that going on. Has anyone else observed that phenomenon?
Hey, Rick, it's Amy Stade. I've
Yeah.
been made aware of that.
If you all can provide me some of that, either the individuals or the providers. I did do a analysis on providers and amount of SCL providers for Commissioner Lee, and I can share that with you all. I will let you all know SCL has more providers than the other well, I have to exclude Michelle Pete because they use SCL providers, so it's hard to determine with them. But the other 4 providers, there are more SCL providers than there are for the other 4 waivers combined. And then we looked at the number of providers that had chosen not to, that had either terminated their contract with us as a provider or did not renew. And there's not a great number. So we can definitely, we can look at that. And Amy, that I understand that there's some of them that where there's been some provider terminations recently that would result in referrals to different residential providers.
Yeah, and I'm told that those providers that are going out of business tended to have a lot of a good number of their folks were folks with the greatest support needs, and so it may be difficult to find providers for
So
those
if you all can,
individuals.
I would appreciate if you all can send me if you have any providers that are going out of business. It's not with the data I can get from the provider portal, it doesn't line up. So that would help me to be able to provide more information to you all.
Yeah, and of course, I'm not making a scientific.
Right. No, I understand.
I'm just looking at what
right.
seems to be going on, and it's not, not a good thing. And we've talked about this before, that you got many people who are difficult to serve, and they're sort of a disadvantage. I mean, there's not enough of a incentive to serve people who are difficult to serve, particularly.
Well, and you have to look at too, and I can understand from the provider's point of view, you have the responsibility to keep the individuals you serve safe as well. So I mean, it becomes it's a problem that we really want to look at, and to look at solutions. Part of our the enhanced FMAP funds, part of that, there's some crisis in that, and part of it is to look at, and it's across the waivers, because this happens a lot in brain injury too, is those individuals that really don't need inpatient, but regular residential doesn't exactly meet their needs. So what does something look like in between that? Or what does is there a way that we can transition them into a setting that will help them be more successful coming back, out from a hospitalization, for example?
Right, and as you recall, we did have a task force, talking about those specific issues, remember, before COVID and the test, remember that? We met a few times.
Yes.
And maybe that's something we should, I don't know, maybe this rate study, maybe the increased rates will solve this problem, but maybe, I don't know that it necessarily will.
Well, rates are only part of it, right? It's staff qualifications, it's that they're getting the correct wraparound services. So that's why, I mean, it is part of the it's part of our approved support, our approved spending plan for the enhanced FMAP dollars. So we'll be looking into that specifically with rate study, and trying alongside the rate study to try to look at solutions. And so as those kick off more, those studies begin kicking off more, we'll be starting. So rate study is the only one that has lifted completely off the ground yet. The others, we finished the detailed project plans, and so we will begin forming stakeholder groups and sharing more information within the next month or so. You'll start seeing that because we're going to involve the stakeholders. We feel like it's very important to be transparent. But so you'll start seeing some requests out there for people to join some of those panels to discuss the issues with us.
Well, since I guess we moved to the next agenda item, which is fine. So will any of the Navigant study be used? You know, they gathered quite a bit of data. Will that have some
Yes.
impact on this outcome?
Yes, and so actually the initial meeting, the PowerPoint and everything from that is posted on the website. We're working on getting a different page just for the enhanced FMAP or the ARPA, all of those initiatives, just so it's easier to find. But for right now, until we get that completely built, that is on our DCA website. But we are going to use some of the initial data. We're also going to launch an updated survey. So that's being worked on right now. And we meet again in a couple weeks. We meet again, the rate study work group does, to look about the questions. But we're going to collect, you know, updated salary, you know, and wages data. We're going to look at costs that have changed because of COVID. But there's some of that we're going to use what we had originally and apply, you know, what's the right word, trending factors, or we're going to look at that to update it without the providers having to complete that extensive survey like they did the last time. Now, but that again, we are posting, which is different than the last time. We are posting the meeting. So the meeting recording is out there. The deck that's used is out there. There's any information that we provide to the rate study members is also going to be posted to the website so that individuals that are not on that work group are able to see it. We do ask if you have questions, you know, there's actually 2 different email addresses that questions can come to. One goes directly to Guidehouse and one comes to us. So I'm really excited for the rate study for that work group to launch that survey and to see the information that we get back. I think we had a very productive first meeting.
Yeah. Well, I'm sure I don't have to tell you this, but the world out there in terms of compensation is changing very rapidly.
Well, and I think and I've told other individuals this, it's not just the types of services we provide in waiver or healthcare. There are workforce issues and that every single industry is facing. So, you know, I think it's going to be a creative, obviously the rates need to be updated, in particular for some of the waivers, even more than others. But there's also things we're going to have to look at for, you know, development, for, you know, what else can we do to entice people and want them to work in these types of jobs? Because, you know, we had a workforce issue before COVID.
That's
COVID
right.
has highlighted that even more. And, you know, I think it has become more difficult just across the board for, you know, I don't remember at any point in my life before now that everywhere you went, there was a now hiring sign. There was a text to interview. There was, you know, I saw a sign at McDonald's the other day, we're paying you every day. I mean, it's, you know, and even ourselves as we're trying to recruit staff, we're having trouble. You know, we may have 5 interviews scheduled and maybe 2 or 3 of the people show up. And that's without even any notification that they're not going to. So, I mean, it's a very complex problem that I think it's going to take us coming at it from multiple different angles to even begin to solve. We are participating in a CMS learning collaborative with, I think there's representatives from almost every state on this, but talking about workforce issues and, you know, talking together about things what has worked for one state, or, you know, what are you seeing that doesn't work, to try to come together. So, I mean, it's a nationwide problem, but it's a very, it needs to be addressed. I mean, the individuals that we serve, it becomes a safety, you know, a health, safety, welfare issue. So,
and I assume we're not being constrained by cost neutrality.
We are not this time. That is the difference with the rate study, is that the prior rate study, we had, you know, if you remember, one piece of pie and we had to split the money up the same amount of money, we had the same amount of money, and all we could do was just adjust where the money was. This time we don't have that constraint. So, our goal is to have rates that are similar for similar services, but obviously knowing that there are some rates that would be different because of a different population being served. So
Yeah, so we'll probably see some merging of some services that are similar.
we probably, yeah, you're going to see, and
Yeah.
I think this will help providers where you don't have, and it'll make it easier to serve different populations, is if you don't have 5 different definitions of a service, or you don't have documentation requirements that are different, depending on what waiver you are. We're looking at standardizing the some of the, I guess, job descriptions is the best way, or qualifications that individuals need. Like for case management right now, it's a little bit different based on each waiver, but we're also looking at that in general. And with the tornado Appendix K version, we made some changes. We included that in our, and Rick, I guess I'm going on to the next agenda item, but we added that to the modification Appendix K that we have at CMS right now, looking at changing some of the qualifications for case managers, as well as for some of the personal care type services that would allow some of our individuals that maybe they're 18, but they're in either a nursing school program or, some type of health-based college program, or they went to high school, or they're currently still in high school, but they participate in that the health and vocational track that will allow them to also serve in some of our programs. So I hope that is going to help as well with staffing.
Well, and just a couple comments. It's not only just the rates that are that there's discrepancy, but the units of service that can be delivered.
Right. That's
really gets messy and confusing and.
Right. So we're looking at trying to make where it makes sense for things to be standardized across the waivers. We want to do that, but we don't want to lose some of the, where it makes sense for them to be different too. We don't want to lose that.
Right. I understand. Just off the top of your head, I mean, what kind of assumption are you making now in terms of compensation rates, let's say for a
I am, so Guidehouse is absolutely the expert in that field. And so there will be more coming out. We'll share that. So I don't really have that to share right now. And that would be something they can best speak to, and will be shared through the rate study. The updates that we do through the rate study. I think part of it too is going to be really interesting to see what individuals are doing, what individuals are paying right now, to get the information back from the providers. So when we've charged the rate study work group members with, cheering on there or encouraging peers to fill out the survey when we send it out. And so, hopefully I'm encouraged to see what we get back from the different providers as to what they're doing, and to really understand, what, how things have changed for them with COVID.
Okay. Are there other questions on the rate study, please? You can enter something in the chat line. There's so many of us on this call here. I don't see any other questions. So you've already touched on the Appendix K.
Yeah, so
update.
I can give you a little, so other things that are in that Appendix K is there's some short-term provider relief ahead of, the rate study, because obviously it's going to take time for the rate study to be done, and then we'll have to modify the waivers, we'll have to modify the regs. So we've added some short-term provider relief options. I don't really want to speak on those until we get the final approval back from CMS. We're expecting that hopefully this week, but as soon as we get that back, then we'll communicate that information out, as well as everything that this Appendix K includes, because as I mentioned, there were some changes for the required qualifications for personal assistance providers and case managers. There were some changes in residential for ABI to match more of SCL. So that we'll communicate that as soon as we get that final approval back from CMS.
Do you see any permanent changes like in telehealth or anything like that that's going
We
to
are looking at,
survive the crisis?
so we are looking at, and actually are looking at a option for MWMA and building in a kind of a virtual visit component. I think it will have its place in the waiver. However, we also have seen some detrimental impacts from it being all, being in particular case management being all done by phone. And so we're encouraging more of the face-to-face type so that you can see the environment. But there is absolute value in those face-to-face visits too. So I think it'll be modified. I think that the telehealth or the virtual visit option will still have its place. But I also think that, we're going to we need to start transitioning back to face-to-face visits for some of those individuals.
Just my opinion. Yes, I agree with you on case management.
Yeah, I will give you, here's the example that I use all of the time. I had a little girl that was on Michelle P. Her brother was her caregiver. She really was nonverbal except for some grunts or some, really unintelligible noises. And the case manager took her essential grunt as her being okay, and she was not okay. We ended up finding out that this little girl was tied to a bed.
Oh, which you
And
couldn't
so
see on.
You could not see, right? And
Wow.
so, even if they had done it by Zoom or by FaceTime, they could have requested to see her. But, so there have been some bad things that have happened. And there's also, people are proud and they may tell you, oh, I can walk. But if you see them face to face, they can walk, but they're holding on to every single thing just to take steps. Or yes, I have food, but if you go and look in the refrigerator, they really don't. So, I mean, there is value in those on-site face-to-face visits. So I think it's going to become a combination of the two. But I definitely think that face-to-face is necessary.
I appreciate that. I agree.
Hey Pam, it's Amy, and I just want to jump in and say I completely agree with you. As an association, we're supportive of allowing virtual visits, just allowing them to exist. I can see the benefit for behavior supports in emergency situations, get the behaviorist on the phone right away instead of having them drive an hour. For case management, in limited instances, like if the family or the individual's sick and, we can't physically be together in person, things like that. The only thing I just wanted to add, and I don't think that you're talking about right now doing anything, but I just had to add it in, just with gas prices the way they are, as much as we can do face-to-face, on a computer screen or FaceTime, Zoom, whatever, and try to limit driving, because as we just talked about, wages are low and gas prices are high, and it's just not a great combo.
And we're considering that, but I also am going to trust the case managers to know. So if you have an individual that has natural supports and, that really has a strong network around them, then you can look at a different type of visit versus somebody that really were their natural support. So, and I trust the case managers to make those judgments. We are beginning, as of April 1st, our nurse assessors for HCB will begin doing face-to-face visits for assessments, unless, the individual requests, they have a concern and they request that it not be face-to-face, we're going to honor that. However, in those cases, we are going to try to do the visits by Zoom so that we can at least have eyes on the individual. So, we're looking at, how do we make, what's the blend, what does it look like? And I think it'll continue to evolve. But you're right. I mean, rates, gas prices, all of that play into it. But, ultimately we need to do what is best for the individuals. And so I'm going to trust the case managers to make those judgments, to know if it's somebody that, that face-to-face visit or a telephone visit is okay versus this is somebody I really need to go have eyes on.
Yeah, I got you. And in these situations, especially with the populations that these providers serve, it's impossible to make good blanket policies that work, in every
Right, I mean, it
situation.
really is. And, the whole basis of these programs is that they're person-centered. So that's what we keep going back to is, what's best for the person? What does the person want to ensure they successfully can be served at home? We want them to be able to continue to be in the community and not have to go to the hospital or go to a facility. So it's ultimately about the individuals that we serve and what they need.
Well, it's going to be interesting to have these conversations then, isn't it? As you work on the rate study. And
I think it is. I'm
Yeah.
really excited for, as we start talking about these, some of these issues. I think there's going to be a lot of good, robust discussion. And so I really look forward to working with individuals, providers, advocates to, really to continue to advance the program.
Is there anything to updates on EVV? Oh,
So I can say two things. One is, so the system is, we haven't made any changes with NetSmart. We realize there are still some continuing issues. We're working with individual providers on those. There was some confusion. I saw, had an email yesterday about, actually, Amy, I think you might have sent it, and Alicia may have answered about mandatory billing. So it is not mandatory to bill the services through NetSmart. The providers can, and we do have some providers that do. The only thing right now that is mandated, however, is just capturing the visit information. So that's what we have to report to CMS. So that is the only piece that is mandatory right now. They can choose to bill claims, but they do not have to. The other thing that I can say is there is an open procurement, and I cannot speak anything else about that.
you know
Hey,
that.
it's Pam is locked into silence.
I am. I will not. I do not look good in orange, and I don't want to go to procurement jail. So,
just an FYI, CAP is submitting a letter. It is addressed to you, but it is only addressed to you because we can't mail things to NetSmart. We realize that none of these things are your fault or you don't have any control over the system, but it's more of an FYI, we're putting together a list in one place for you to look at of just issues that have been reported amongst us, just so you have it and can give it to them.
well, and
in one place.
I do have frequent conversations with NetSmart. In fact, I have a meeting with them today at 1:00. So we continue to work with them, and please encourage any providers, if you're having an issue, reach out to me, send something to Medicaid public comment or to the help desk, because I will just be honest, if you send it just to my email, there are times that I do not see it until later, and I wish I could have seen it before, just because of the volume of emails I get. So if you will have them use the help desk or Medicaid public comment, then there are other people that see them that can point it out, or that can take action outside of me. But we still are working with them on every issue that's brought up, trying to solve problems. But I'll look for that, Amy, and we will discuss it with NetSmart.
I appreciate you, Pam, and I'll tell you just on this, one of the biggest issues is the reports that they can generate where the billing code's missing now. Yeah. Okay. That's one of the bigger ones.
Yeah, that's one we're having a discussion about right now.
Okay,
So.
perfect. Perfect. Thank you.
Yeah.
Yes, thank you. Continued masking requirements. I have a question. When the state of emergency ends, does that end the masking requirement?
So we will continue to follow whatever the CDC's guidelines are. At that point, I do know I've gotten another question from a provider about the guidance that was sent out very, very early. I think when we reopened the ADTs and adult days, I've sent that on to the task force that worked on that. But honestly, we are relying on providers to monitor what the CDC says and to have their own policies and to make the decisions. There's not been any other guidance, and actually anything that we've put out has been a guidance, not a mandate. So I have that meeting on Thursday of this week, so I can bring it up with that task force group and see if there is a plan to generate an updated one of those documents. But I believe it honestly is going to be, follow what the CDC is saying and what you believe is best for, what your centers look like, or what the situations you're serving individuals look like. What's the best for you all in that situation.
Does that mean that the enhanced rate for residential 1 stays in place?
So right
Definitely,
now,
or,
so that's part of Appendix K. And
Yeah.
so Appendix K is in effect 6 months post the declaration that the federal public health emergency is ended. So the state PHE may end, but everything under Appendix K goes under the federal PHE. And so we expect to hear in April, what they are going to do with that, if it's going to be extended anymore or if it will be continued. There's kind of varying opinions amongst the different associations what's going to happen. But once it does end, we have 6 months to transition back.
Okay, so it's essentially a federal decision on
It's the federal, yeah.
Yeah.
Appendix K is based on the federal public health emergency.
and that's where the enhanced rate is.
That is where the enhanced rate, yeah.
Right. But if I just if I understand you in terms of masking requirements, you're leaving that up to providers.
Based on following the CDC guidance.
I'm not aware of anything that requires masking in the CDC guidance. Are you? Are you aware of anything
I
particular?
really am. I don't honestly have enough knowledge of it to
Yeah.
speak to it. I would need to go and look it up. So, which is the same thing I would advise you all to do.
Okay.
Is to
Okay.
follow any guidance and monitor for new guidance issued by
Okay.
CDC.
Well, that's good to know. Anything else on masking? Anyone? Waiting lists,
Okay,
standing
so
items.
SCL, we're at 2,927, 108 on the urgent, 2819 future planning. There are 0 on the emergency. For Michelle P, we are up to 7,596. 5,708 are under 21. 1,888 are over 21. So that's at about a 75%. So that's inched up a little bit. We've been hanging at about 72% under 21, but we're up to 75% on the wait list that are under 21. And part of the enhanced FMAP, we have a group that is going to be lifting off to look at wait list, in particular Michelle P. But to look at wait list and is there anything that we can do to change that, or what, really looking at it in general.
Yeah,
So that would be coming soon.
Yeah, we brought this up many, many times, and it's not that you disagree or don't see that it's important, but the whole idea of some kind of a pediatric assessment for.
That
eligibility.
also let me, so
Yeah.
that leads me to, I can give you updates on two other things. One, we will be looking at a validated assessment tool. And we also are doing a feasibility study on children in waiver and possibly about a waiver focusing on children. And that also looks at the serious emotional disturbances as well. So
Interesting.
that also is going to be starting within the next month.
Well, that's interesting. Does anyone have anything else? If not, we are adjourned. Thank you.
Thanks, Rick. I'll get those reports to you so that you.
Appreciate all your hard work on that. I know it's a lot of work. Thank you.
Thank you.
Pam, do you also mind to email them to me just so I have record?
I will do
Thank
that.
you.
Absolutely. Okay, thanks.
Thank you.
All right, bye.
Bye.